Let's just go ahead. Hello, everyone around the world. Thank you for joining us in the TBPPM Learning Network next webinar. We're very happy to see all of you joining us today. We have an exciting session talking about the engagement of the private sector in the COVID-19 response and also looking at the tuberculosis side of things. We've been doing several webinars over the last little while, looking heavily on how COVID is impacting the tuberculosis services. And one of the things that the TBPPM Learning Network is really looking at is engaging the private sector. So we felt it of an incredible importance to actually look a little bit broader than tuberculosis and see how the private sector is involved in the overall COVID response. So that's going to be our session today. We're going to be recording all the presentations. Everything that you will be seeing today will be uploaded in a couple of hours after this session. Everything will be available on our network, also on YouTube, in our channel, and we are having a Q&A open for you. If you have any questions during this webinar or after the webinar, please feel free to post them in the Q&A or get back to us. We will have 20 minutes of time during the webinar to answer your questions. I am just going to say that we have two really great speakers with us, and I'm very excited to introduce Dave Clarke, who is a specialist in health law and policy. He works at the World Health Organization and is specializing in several areas related to law and policy related to the universal health coverage, and especially looking at the private sector engagement. So we're really pleased to get all this experience. Recently, he's been very engaged also in the COVID-19 response. So to hear his work and the WHO action plan in this regard is what we will be listening to in the first presentation. And then secondly, we have with us Professor Venkat Raman. He's a professor at the University in Delhi in India. He's engaged as a special advisor in many multilateral initiatives globally and has a lot of experience to share. Today he's going to talk to us about the engagement of the private sector in specifically in India, and is going to show us several examples and a lot of background information. So we're really pleased to have a touch on not just the COVID response in India, but also the tuberculosis private sector engagement in India. So with that, I would like to say welcome everyone. Please use the chat function, the Q&A function for any questions. And with that, I would like to ask David Clarke to please start with your presentation.
Thanks, Petra. Can you see the slides okay?
Not yet.
How about now?
Now we're going to your screen.
Okay.
And we're seeing the Zoom, but we're not yet seeing your presentation.
Okay. I'm not sure what's going on because I think I'm sharing it, but I don't see why it's not.
Maybe. Yes, here we go.
Oh, there we go. Okay, sorry. Okay, so hello everybody. So I'm David Clarke. I work at WHO. One of the topics I work on is working with the private sector. And prior to the COVID-19 outbreak, we were very focused in our work on working on the private sector to help achieve the universal health coverage goal. But with COVID-19, everything's changed, and we've changed our work around, and now we're focusing on how we work with the private sector as part of the COVID-19 response. So why is this important? Well, COVID-19 obviously has triggered a global surge in demand for health services for all countries, not just the developed countries, but also low and middle income countries. It's really putting health systems under huge stress. And in response, all countries are trying to urgently increase their capacity to respond, both to trace and treat COVID patients, but also really importantly, to maintain their essential health services. So what sort of things are governments interested in? Obviously, they're interested in establishing their essential public health measures to minimize the spread of the epidemic, and things like information and communication, surveillance, and really importantly, and been in the news a lot, the whole testing issue. There's also obviously the need to facilitate treatment for people with COVID. There's a big initiative around managing stocks of essential materials, test kits, ventilators, oxygen, etc. Ensuring that health workers have access to personal protective equipment. And it's really interesting how this is playing out. I was having a conversation yesterday with some colleagues from the Global Fund about people who are involved in distributing bed nets, not having access to personal protection equipment, and consequently not being able to distribute materials in relation to malaria prevention. So there's a lot of issues here around the access to personal protection equipment beyond the actual direct response. And then obviously, lastly, protecting the vulnerable in our communities. So why are we focused in on the private sector? So we've been focused in on the private sector as part of our universal health coverage work, and now because of our COVID work, just because of the size of the private sector. We undertook a survey in 2019 to look at the sorts of numbers that we have in relation to private sector care seeking across all the WHO regions. And I'll go through this really quickly, but in summary, in most regions, over 40% of care is provided in the private sector. So it makes sense that if governments are going to work towards their health coverage goals, they have to work with the private sector and they have to pay attention to the private sector. So I'll just quickly go through these slides. In the EMRO region, we have very high numbers of private sector provision. And what's really interesting, if you see from these graphs, is that care is sought across all wealth quintiles, from the poorest to the richest. We have very high levels in the Afro region as well, also in our Sierra region and in our Wipro region, and also in the Paho region. We're just in the process of updating the information you have about the Euro region. But overall, I think the main point to note is that if we're going to respond to COVID-19 and provide capacity for the response, we have no choice but to work with the private sector. So I thought it's really useful to have a look at what the results of working with the private sector might be. What are we seeing on the ground? Governments have already been working with the private sector as part of their COVID response. And we have some really good lessons from the European region. And I'm sure Venkat will also share some lessons from his region as well. So if we look at what's happening in the European region, in England, a lot of work was done to bring the private sector into the response. And that's resulted in extra hospital beds, extra ventilators, extra health workers. It's made a significant difference to the capacity of the National Health Service. If you look at other countries, if you look at Italy in the Lombardy region, which is particularly negatively affected by COVID, a lot of work was done in that region to bring the private sector into the response. And again, bringing in really material capacity increases, extra beds, extra staff, and all sorts of extra resources. And also we see this in middle income countries as well. So the South African government moved very quickly to see what it could do to bring the private sector into the response, and undertook various institutional changes to the way in which the health system is organized to make sure that it could do that. So for example, bringing in new reimbursement systems for the private sector. And what's really interesting about all of these countries is that they long have had institutional frameworks for working with the private sector. They have reimbursement systems, they have contracting systems, they have systems for public-private dialogue with the private sector. And as a result, they've been able to mobilize the private sector quite quickly for their response. But the challenge that we're finding is that this isn't a universally level playing field, that while many countries have been able to quickly scale up for their response, leveraging more beds, more health workers, and in some countries, lab capacity, a lot of countries are not able to do that. And low and middle income countries, many countries don't have the institutional arrangements that the high income countries have for working with the private sector. Often the private health sector is unregulated and disengaged. And it's crucial that these countries, particularly as these countries don't have such significant health system resources as the richer countries, that they work quickly to align the work of the private sector with national responses. We have seen in the early days of the response, low and middle income countries working with the private sector, but they tended to work with the private sector outside of health. So telecommunications and companies and mattress companies, beer companies, etc., were all brought into the response at an early stage, but not so much with the private healthcare sector, though that is changing. And we are seeing a number of countries where, particularly in the African region, where the private healthcare federations themselves have organized themselves and are working quite closely with the government as part of the response. And what we're doing at WHO HQ with our regional colleagues is to see how we can change the situation in LMIC countries, how we can support them to work more productively with the private sector. And with that in mind, the first thing that we did was produce an action plan for ministries of health and private healthcare associations to respond to COVID. And this action plan is arranged around 6 pillars. 1, planning, just getting everybody together and getting organized. And there are a number of countries who've done this really well, but there are some other countries who are really struggling with this. In fact, I've got a call tomorrow with a member state to talk about how we can support them with this phase. The next part of the action plan is about space, and that's about securing private sector assets to increase surge capacity for the response. The third aspect focuses on the crucial staffing issue and how we can mobilize both public and private health sector staff. The fourth aspect is about stuff, ensuring that all health facilities and staff have the supplies they need to respond. The next piece is about systems and making sure we have systems to better integrate the public and private sector response effort. And an example of that is making sure that the public and private sector are using the same clinical protocols to ensure that there's a seamless response effort across public and private sector. And then critically also how we pay for all of this, how we introduce supply side financing mechanisms, particularly in countries which might not have had a long experience of working with and funding the private sector. And in terms of the work that we're doing at WHO, we're doing it in 3 phases. So in this first phase, we're really focused on the emergency response in real time and seeing what countries' problems are and what their needs are. In phase 2, we're planning to move to a more peer-to-peer support mode, where we want to link countries with their other countries who already dealt with the response to see what they can learn, and also to link them to experts who might be able to help them where they have specific policy problems. And the last phase, we're planning to set up a virtual coaching support for supporting countries to improve their capacity for private sector governance. All of this information is in the slides, and we'll, of course, make the slides available to everybody on the webinar. And just to illustrate a little bit more about what we're doing with these various approaches, the first part of our approach, we don't presume to think that we know all of the issues and problems that are out there. So in this first part of our work, we're working really hard to identify and frame the different problems that the countries are facing. And we're really aware that countries are facing different problems depending on what stage their response is at, whether they're in the containment stage or the mitigation stage, they're going to be facing very different problems. We're already looking to see whether or not we can repurpose existing resources that will help countries to work with the private sector. This is not a new topic. The whole topic of private sector engagement's been around for a long time. And we're going to try and repurpose things to help countries to deal with the specific problems associated with the COVID response. And then we have this plan for the real-time peer-to-peer problem solving, which we've discussed. We're also planning what we describe as country-level sprints. So this is very intense technical assistance to help countries to deal with their challenges as they arise. And then in the longer term, we're really, really conscious that all of this work and the whole COVID situation is going to change the way in which health systems operate in the future. And we anticipate that governments are going to want to have a very close look at the lessons learned from the COVID situation. So we're doing long-term research as well to help inform the next stage after the COVID response, the recovery and replenishment stage for health systems. And then just to quickly wind up, just to illustrate a little bit more what we're doing and go into a little bit more detail. As part of the problem identification stage, which I mentioned, at the moment, we've just finished some research and published a document about key policy challenges in the containment stage of the response. And this is based on work we're doing with a number of low and middle income countries across the different WHO regions. And here are the key lessons that we've learned already. And some of them are actually long-standing problems with private sector engagement, which many of you will be familiar with. The first lesson is that some countries just don't know how to bring the private sector into the response. Some countries don't have institutional arrangements for private sector engagement, and so they're struggling. The second issue is that the resource-based planning for the response is really difficult to take place because there are critical data gaps. Again, this is a long-standing problem with the private sector in many countries. There are big data gaps. The third problem is that in many instances, the private sector are telling us that they lack the inputs they need for it to play as an effective partner, role as an effective partner in the response. We're also finding that some countries' emergency legislation, compounded by weak governance systems and regulation, and problems with regulation, is actually limiting the private sector's role, and we can give you some examples of what we mean by that. Countries are also really struggling, particularly those countries who don't have existing reimbursement mechanisms for working with the private sector, on how to best reimburse the private sector. And the last policy issue that we wanted to raise, and this is something we're going to do some more in-depth work on, is that obviously a lot of businesses around the world are going to fail as a result of COVID. And what does it mean if private healthcare businesses fail, particularly in countries where private healthcare businesses are providing such a big proportion of health services? So what should governments do about that? And at the moment, there are very few criteria for governments to make strategic decisions about which aspects of the private healthcare system it might want to support in the longer term. So all of these issues are discussed in more detail in this new publication, which we published today. The link to it is at the bottom of the page. It's on the Health Systems Governance Collaborative website. The Health Systems Governance Collaborative is a WHO initiative, which is a partnership between different organizations who are interested in health systems governance. And over time, we are going to populate this particular website with more information and more products as we develop our COVID-19 response efforts. So in terms of next steps for all of this, we're going to continue to work with countries to implement the action plan, which I mentioned. We're also going to work with countries to address the policy challenges that we've identified as part of our recent work. We're very aware that there are already best practices and resources and tools out there which can help, which we can repurpose. We're also working with development partners who work in this space. So the World Bank, USAID, DFID, etc., all of whom have really good tools and resources, which we want to share. And we're also very keen to make sure that we work with our member states so they can learn from other countries who have progressed through the different phases of the pandemic. We're really conscious that there's a whole group of countries who are currently in the containment phase, who are going to very quickly move into the mitigation phase. And that's when their health systems are going to come under significant stress. So I'll stop there, and thanks for your attention, and I look forward to any questions or points of clarification. Thank you.
Thank you so much, David. That was really great to hear all the details that you outlined and the full-on plan. Thank you for putting out the slides as well, and for going through all of the action plans. I would like to ask Professor Venkat to put his slides up right now and maybe go straight in his presentation. And we will take any questions for David's presentation and Professor Venkat's presentation after the next presentation. So Professor Venkat, if you want to share your screen and pull up your presentation.
Trying to do that, yeah.
Okay, I also want to let you know that we have with us Guy Stallworthy and Madhu who will both be available for questions when they come up in the panel. Guy is going to be helping out with the moderating of the many questions that come in as well. So please feel free to also post your questions in the Q&A. We will have excellent speakers and panelists to look at all your points from many different perspectives.
Is the slide visible?
Not yet.
So do I drop it?
I think we are starting to see your screen, but now we need to see the presentation.
Would you be able to load that? Because I'm unable to do this here.
Okay, I will have a look if I can pop up. I will stop sharing your screen, and I will try and go.
Okay.
Yeah. You need to stop sharing your screen, Professor Venkat.
Okay.
At the top. At the top of your screen? Yes.
Yeah.
Okay, great. Thank you. Sorry about this, people, but we're slowly getting there.
Okay. Before the slide comes in, is that available?
Yeah, maybe you can just go ahead and then I'll try to pop it up.
Okay. Thank you, Petra. Thank you, Madhu. Thank you, Guy, for giving an opportunity to speak about this experience of India in COVID-19, as well as what kind of lessons we can, or reflections that we can get from this pandemic to TB program. For the audience, let me try to give a very brief background to Indian context. David mentioned already that there is a predominant services in the healthcare is provided by the private sector. India is no exception. India's ambulatory care, almost about close to 75 to 80% is provided by the private sector. And the hospitalization service is also a major player. The private sector is a major player. That's about 60%. So given that context, we also need to understand that in India, the service delivery, health service delivery is more of a provincial responsibility than federal government responsibility. And there are 28 provinces and there are about 9 federally administered territories. And not all, the provinces are capable of delivering services at the same level or at the same efficacy. We have a great deal of differences in terms of the health sector performance. That is a reflective of health sector governance of various provinces too. So that's more or less what is the background to the Indian context. Coming to the pandemic as such, the status of pandemic in India, there are about 53,000 cases right now in India, and a recovery of about recovered cases of about 15,300, and a total death of about 1,783. So about 4 of these provinces out of 28 provinces contribute to more than 60% of the cases. And there is a great deal of, in the spurt in the number of cases in the last few days. So that's more or less the context. Can we go to the next slide? Yeah.
Can you see the slides?
I can't see, but I am assuming that others are able to see.
I'm sorry, I can't see it when I'm sharing. I can't see what the audience sees.
We can't see slides, Petra.
Oh, you cannot? I'm so sorry. How is that possible? Okay, I will go back. I will try it again. Please keep going, Professor Venkat. I will.
Okay. The next slide is giving you a broad indication of about the complex web of relationship that can exist between the private sector and the government in terms of providing.
We can see it now. We can see the slides.
Thank you.
Yeah, the second slide, please.
The second slide is the one on screening.
Yeah, that's where the diagrams are there.
Okay, yes.
Yeah, this is the one.
Here we go.
Yeah, so you could see that the government's relationship with the private sector could be under a variety of options. So what I am looking at, what I am going to touch upon is not all the areas of focus, but only on the areas of 2, 5, 6, and 4, which means that the diagnostics, the supply side, the hospital supply side, the treatment and hospitalization, and the IT support. So let's look at the next slide, please. So you would have the testing and diagnosis. In terms of testing and diagnosis, till about the morning today, India has tested about 13.5 million, conducted to 13.5 million tests. That's about close to about 100 cases per million per test. We also have a total number of about 453 labs. That's a changeover in the today. Till 5 o'clock, it's about added to 453 labs, and 121 of these labs are in the private sector. So all of them are highly accredited labs. These are called National Accreditation Board for Laboratories, and the usage of CBNAT and TrueNAT also into play. These are usually for the TB cases, but then they have been repurposed for this particular purpose. And there are 3 times more of sample collection centers all over the country. Last count I have is about 1,400 to 1,500 sample collection centers. This is more or less the way that the government has spanned out the testing infrastructure. Now comes to the question of how do the private sector need to be engaged in testing. Initially, the government gave an order that all laboratories, private sector laboratories, should test free of cost. Then they ran to the Supreme Court saying that they cannot do it free of cost. And then the Supreme Court gave a judgment, or rather an understanding that there has to be a cap in the total price of each test. That's about $60. Now, the government again appealed to the Supreme Court, and the Supreme Court finally came up with the notion that government should ensure no one is forced to pay from their own pocket. That's more or less the kind of understanding. Now, the federal government had allowed the individual provinces to devise their own system of asking the laboratories or empaneling the laboratories. The laboratories are already in a large list prepared by the federal government. Now the payment has to be made by the provincial governments. So far, there are no guidelines as such in terms of how the private sector will get a reimbursement for every test that they do. The cap is about 4,500, but they would charge any patient who wants to test it in the private lab. But the private lab, if it is forced to test free of cost, then there is no way that they are going to get any reimbursement. Can you go to the previous slide? Yeah. What are the options which are mentioned there? One of the options that we have suggested, and it is already in pipeline or already in the implementation stage, that instead of sending the patient directly to crowd the hospitals or test laboratories, why not use a telehealth or telemedicine consultation center for a preliminary screening, and only after that you could send them for the test possibility. So an additional feature that could be added is the issue of e-vouchers that is possible for the patients to take through the smartphone and go to the laboratory for testing. This is a suggestion that is being made, and there is a telehealth center that is already functional in 2 of the provinces, and I hope most other provinces follow suit. There is also an experiment that's going on in terms of mobile-borne sample collection and testing using hub-and-spoke model. But this is again restricted to only in certain urban locations, but we have not yet seen it in tier 2 and tier 3 cities. So what we are suggesting is that why not use the sample collection center at the primary care facilities in the government so that hub and spoke model. The third area of innovation is that there is a great deal of deployment of big data, that is machine learning or artificial intelligence, for diagnosing using both X-ray, CT scan, as well as deploying the artificial intelligence for contact tracing. The fourth area of concern is that India has almost 550 medical colleges. Half of them are in the private sector. More than half of them are in the private sector. But since their laboratories are not NABL accredited, so there isn't a way that these medical colleges are brought on board for testing. So that's one of the areas of concern. So can we go to the next one, please? Yes, now the hospitalized treatment, what the federal government did was they had categorized patients into 3 categories and had deployed resources accordingly. So the first category of cases were called as mild cases. They would be isolated and quarantined with beds and whatever are their essential supplies or support that they need to get in terms of food, etc. Now, for example, Indian Railways had converted about 5,000 coaches, and each coach, 8 beds were converted. 8 compartment or 8 partitions were made and into 8 different beds. So it's almost like a surge in the total number of isolation beds, multiplied by 8, 5,000. It's about 40,000 kind of beds are available at this juncture. So likewise, you will see on the right side, I have put the data about the total number of beds that are isolation beds that are available. It's about 194,000. Remember, this is the last week's data, and this is the government's own plan for any surge in the cases. The second category of patients are moderate patients who show symptoms, flu-like symptoms. They are admitted to dedicated COVID health centers. Now, they are given isolation beds, and these isolation beds, some of them could be with ICU or not necessarily with ICU. There is also ventilator and oxygen support facility. Then there is a third category of people who are severe, and these are dedicated COVID hospitals. They are not called as health centers. And these are severe cases. And apparently in my discussion with the people, not more than 3 to 4% of severe cases require intensive or invasive ventilators. So at any given point of time, hospitalized patients, there aren't more than about 200 to 250 cases who are in invasive ventilators. Now, what are the possible suggestions that we have been giving to to the government? One of the suggestion is that since these, the pandemic and simultaneously the upsurge in any cases is going to be a kind of a long drawn process, why not allow a PPP model of ICU wards being set up in tier 2, tier 3 public hospitals, so that there is their own capacity to handle the severe cases could be kind of scaled up. Now there are 2 ways: either the ICU wards are converted and by the private party and they handed it over to public hospitals, or ICU wards are created and managed by the private hospital provider. So these are 2 options. Now, right now, the treatment package or tariffs under what we call it as Prime Minister's health insurance program, apparently the private sector is extremely unhappy because on an average you require more than about 35,000 rupees per day of ICU charges, and the government is willing to pay only 4,500. So there is an element of debate or discussion that's going on right now. Can we go to the next slide, please? Yes, this is where a great deal of hiccup has been happening, because most supplies, close to 90% of supplies, especially on ventilators and chemicals and reagents and cartridges in the case of CBNAT machines, have been imported. Now, these test kits have been, bought or ordered by individual provinces directly with the international manufacturers. What has been happening is that the provinces were overbidding each other's. So when central government wanted to, or federal government wanted to really procure together, many provincial governments did not want that to happen. So there was an element of little political economy or political dynamics into this. So we'll, at this juncture, there isn't too much of a scale up of any low cost indigenous production of these test kits or RT-PCR tests, etc. However, what I heard in the last couple of days is that there has been a huge scale up in the production of PPE, at least in terms of overalls, gowns for hospital staff. And this has happened apparently right now. India is the second largest manufacturer of PPE overalls. So it's a good news one way in terms of the way that the Indian manufacturing sector has scaled it up. Now, coming to some of the thoughts that we have given is about capex subsidy, speeding up the licensing and regulatory approvals for manufacturing, centralized procurement based on indents from states, and that has been a difficult one. But we also said that why not give free or subsidized supply to the private sector, so that the private sector can only charge service charges rather than charging the for the kit as well as for chemicals and reagents. So can I go to the next slide, please? Yes, there have been several other areas in which the private sector has been, the private sector involvement is possible. One of the areas is that staff attrition, especially due to infection and the need for rest, has been a great deal of problem in public sector hospitals. Right now, most of the cases are handled by the public sector hospitals, whereas in public sector hospitals, the staffs are less as well as their attrition level is very high. What we have suggested is that why not allow independent pulmonologists or private practitioners who could be contracted into the public hospitals on a temporary basis in terms of their consultancy fee or any other supply side mechanism. One of the major problems that many of you may have seen it in television channels is about our migrant laborers wanting to go back to their respective places. And this has created a huge surge in the number of, or a fear of community spread. So what has been happening is that the CBHOs and NGOs have been roped in to provide the hostels and shelters for these migrant laborers. But unfortunately, many of these shelters are not fully equipped to handle their day-to-day requirements or needs. Therefore, many of these laborers have been coming to the street, walking thousands of miles and going back to their respective native places. I'll skip the last part. Go to the next slide, please. Yes, the private sector story in India has been a major problem because most private sector people have been telling me that these are quotes that I put in. They have been told to stop all other non-essential services, all other kind of services. As a result, most of the private hospitals have waited for the government to refer the COVID cases. But government has not been sending or referring any of the COVID cases to the private hospitals. So one of the quote that I have given here is a very senior private sector functionary who said that we were led into a garden path only to be abandoned because so far not many many cases have been sent to the private hospitals. In any case, the private hospitals are in a mess because most of the private hospitals in India are up for sale, and you would some of you would know that there has been a great deal of acquisition of Indian private hospitals. But what has happened in the last 2 months is a kind of a body blow. The body blow has been that no cash inflows or cash flow has happened in the last 2 months. So many of these hospitals are without any kind of capital to function or working capital to function. So the private hospitals are also extremely, fearful that if they admit a private patient or any COVID patient, and even if one of the staff gets COVID positive, there is a possibility that their hospital would be sealed. And this has happened in several places in India, and therefore there is a reluctance for them to admit cases. So far, Government of India has not, neither state governments have come up with any kind of a policy or guidelines to reimburse the private hospitals. The low rates of the insurance packages have been a deterrent for people to really, be empaneled. So can I go to the next slide, please? Yeah, TB elimination program. What kind of lessons we learned from this to the TB elimination program? Some of you would know that in India, we moved towards performance-based contracting of private sector. One of the major, the casualty of the pandemic, COVID pandemic, has been low case reporting or new case reporting in the last 2 months. This month, instead of 200,000 per month case reporting, only about 38,000 cases have been reported in the last month. So it's we don't know whether this is due to lack of entry of data or due to lack of testing for the new patients. A lot of TB patients have been deputed to COVID team because many of these are contract people. However, I keep hearing that the existing cases are looked after well. Their drugs have been even supplied at home. There is a call center. There are grievance numbers that have been given, and the dot centers are functioning well. So dot centers are not closed. Can I go to the next slide, please? Yeah, I'll try to be quick, just about a couple of minutes. So what are the lessons or learnings and reflections from the COVID pandemic into TB program? So we can actually think about categorizing TB case intensity according to geographic clusters and refocus ourselves and our resources in terms of red, green, and orange, or focus on more of red and orange. That's one major possible take-home lesson. The second is perhaps this particular pandemic had opened up a lot of avenue for home-based or primary care facility-based sample collection, transportation, as well as telehealth consultation. Maybe a time for us to really expand that scope. We also have Arogya Setu as an app, which has been one of the largest downloaded app for self-assessment of corona or COVID-19. A similar possibility or similar app is possible with the TB cases too, so that we are able to track, monitor their adherence behavior too. There is also a possibility of integrated testing for TB or COVID using CBNAT or TrueNAT facilities. So if not today, maybe 6 months from now, if there is a possibility of an integrated test using the similar kind of technology available to us, perhaps that can also add into more optimal resource utilization. Can I go to the next slide, please? There is a possibility that, again, this is a reflection. This is nothing to do with what is happening, but just a kind of a thought. Why not have a comprehensive lung health program and an integrated diagnosis in hospitals? This can take care of a lot of COPD cases, as well as some of the emerging lung diseases that are this kind of pandemic. Exploring private home delivery of drugs is another option. Now that this pandemic has created a huge desire for sanitizing or UV ultraviolet lights or open waiting areas or even compulsory masks, TB centers or TB wards can also create or provide a similar kind of support options for patients walking in and walking out. The last one in this case is in terms of a couple of other points is think about strategic purchasing. Already MDR cases, there has been a kind of a package rates that have been thought through. Why not think about cohort-based treatment or a peer group follow-up? If there is a question, I can answer on that. Aggressive risk prevention campaigns, which has happened for this COVID case, so we can try doing a very similar kind of a thing. Artificial intelligence platform is already kind of a deployed. X-ray analysis in Mumbai is one of the cases to expand. We can also look at adherence behavior analysis using artificial intelligence platforms, which can help us to give us a predictive analysis. The last, the first slide, I will close here. Okay, so I'm being thankful to all the people who have been at the forefront. I just thought that this particular slide would be appropriate for a lot of people who have been working at the background. Thank you.
Thank you very much for the presentation. That was really very useful and lots of practical details. I would like to ask maybe Guy Stallworthy to take over from me here and maybe pick out some questions to comment on and help further guide the discussion.
Thank you, Petra. I hope everybody can hear me well. Thanks to both the presenters. This was extremely rich. And we have dozens of questions have been posted. I'm just going to pick a few of them with the time remaining and put them out to you, maybe starting with you, David, to give Venkat a bit of a break. And Madhu, feel free to join in as well. First question relates to the private medicine retail sector, the chemists, drug shops, as well as formal pharmacies. In many countries, these are the first point of care, and in many cases, some of them are less than fully licensed, and there are regulatory issues. Any thoughts about how they might be engaged in the COVID-19 response, or any indicators from around the world that you're aware of?
We haven't specifically looked at the issue of the private medicine retail sector, but I would think that there is a huge opportunity here to use the private retail centre to distribute much needed products. But also, it might also be an opportunity to try and start to influence the quality offered by these centres and bring them into the health system more formally. And I've worked in a lot of countries where these private drug shops operate and they're not licensed at all. And often people are just using these premises to make income. They're not necessarily pharmacists. They don't necessarily have any qualifications in medicine, prescription or distribution. But the whole COVID situation, for me, there's two aspects to it. One, we really do need to look at what we do in an emergency situation and take advantage of the resources that we have, even if they're imperfect. And the second thing is what we can use this emergency situation to leverage. And for us, there's this bigger agenda around how we bring the private sector into the health system and how we improve the quality of the services it offers and how we make sure that it better integrates with the public health system. So to me, there's a big opportunity here to bring the informal drug shops into the response, and a big opportunity to see what we can do to leverage better quality in these shops. And there's a lot of work being done historically on this topic. But to me, the COVID situation is a great opportunity for getting some traction.
Thanks, David. Venkat, do you have any thoughts on that topic before we move on? Has there been any discussion about the role of the chemists and pharmacies in India in this crisis?
Chemists and pharmacists so far have not been consciously looked at. I'm not sure whether there is an element of admittance or at least admission from the government that whether COVID cases, the first doorstep or first level of contact would happen to be, would it be the pharmacist? What they are assuming is that the symptoms, when it persists with a particular kind of level, they can call up a call center, and that call center or an emergency number, and that emergency number would send an ambulance to really verify whether that particular person requires. So far, the cases which are considered as truly suspect cases, they are the ones who are picked up by the ambulance and taken to the COVID hospitals. But some of them who are walking into the hospital directly, they have been, their samples have been collected and they have been told to go home. And once the test results are available, then only they are, followed up. So I'm not sure there is any kind of thought through about the role of pharmacy or pharmacist shops in this pandemic.
Thank you. Maybe that's something for us all to look out for. The next question is a big one. And it's the question of pricing in these strategic purchasing arrangements that are being set up with private providers. It's always a thorny issue. And Venkat alluded to it in terms of the disagreements about the appropriate rate for daily intensive care. How is this being addressed in these emergency situations that you're aware of, David?
Well, we're aware in the European countries that many of the European countries have cut a deal with the private sector where the private sector will provide services at no profit. So in other words, at cost. But what we're also aware of is this is a really tricky issue. And how do you determine the cost of running a health service, and how do you determine what's a fair rate of reimbursement? So that's something that we are doing some work on at the moment. And we're hoping to give some more advice, particularly to low and middle income countries about that. I also want to highlight that my colleagues in the health financing side of my department have issued a blog about purchasing in relation to COVID, and that's on the UHC 2030 website, and there's some more information in that blog about this topic. But the whole question of reimbursement is something that we are planning to look at in more detail as part of our work on the WHO. So it's in the next tranche of things that we're going to be working on. And we focused in the first instance on the containment phase, because that's where most countries are. But very quickly, countries are going to face more and more cases moving into hospitals. And that's where we think there's going to be some really big issues in relation to reimbursement, particularly with those countries who don't have a history of purchasing services from the private sector. So there's questions about pricing, but there's also questions of just about how you actually do it. We are getting a lot of questions from member states about how you set up these contracting arrangements. So there's a lot to work through here.
This follows nicely to one of the additional questions we had, which was, can you comment a little more about how the engagement of the private sector is going to look differently, or does look differently according to the phase that the countries are in, whether it's containment or mitigation? How is it dynamic?
Our work, we recognized very early on when we started to do our analysis of the problems that we had to look at it in different phases, because the issues that countries are facing are going to be really different depending on the phase. So in relation to the phase that most countries are in, which is in the containment phase, there's a lot of emphasis, for example, on testing. So that's where we're putting out, that's where we're looking at what's happening in different countries. And here there's all sorts of issues around the quality of testing, access to tests, pricing. Different countries are taking a very different approach to how much these tests cost. In some countries, the private sector are charging a lot of money for tests. In some countries, the government's picking up the tab. So yeah, there are definitely different policy issues depending on the containment phase that countries are in. And obviously we can learn from those countries who've already gone through various phases of the COVID pandemic, particularly the European countries who've gone through a lot of different phases, and I'm in the middle of having to provide a lot of treatment to people at the moment. So we're trying to learn what we can from the experiences of those countries, and then start to generate advice for countries who haven't quite got into that phase. The one point I want to make is that there isn't a direct comparison to be made between the high-income countries and the low-income countries and middle-income countries. The issues are quite different. And we're very cognizant of this, and this is why we're trying, as part of our work, to build in this problem-solving, problem identification phase into all of the phases of our work. As we go through the different phases of the pandemic, we're very conscious that different problems are going to arise, and that we need to understand what those problems look like in different countries so we can put together appropriate advice. Over.
Guy, can I ask a question?
Please go ahead, Madhu.
Yeah, so this is a question for both Dave and Venkat. So taking India as an example, we already know during the lockdown, huge numbers of people have been deferring seeking care. Even for TB, notifications are dropping. No matter what disease they have, they're waiting and waiting and waiting. And as and when the lockdowns start lifting up, there will be massive numbers of people seeking care for more severe advanced disease, right? With this TB, for sure, they would have waited for 3 months now or even longer, and they would have likely smear positive advanced disease or advanced diabetes, whatever, you name it. Now, given India's healthcare structure, you would think that they would first again seek care in the private sector. But then as Venkat said, a good number of these private establishments are either shut down or bankrupt or may not come back online. So now where will these people go when this massive surge happens in the coming months? If the public sector is in a disarray, the private sector is partially closed or fearful of opening, we're going to have an incredible problem in the coming months to deal with the surge. So what should be the strategy?
Well, we're very conscious of this issue. And what we've noticed in the countries that have already responded to COVID is they tend to have moved into their work with engaging in the private sector when things get really difficult. There doesn't seem to have been any strategic thinking about what's likely to happen at different phases. So that's what we're trying to emphasize, the need for some thinking ahead to these sorts of issues. And we are, and even though it might not seem an issue that WHO should think about, you know, whether we should care about whether the private sector goes bust or not, we do, because just for the reason that you just described. I mean, we're very conscious that post the phase of the pandemic we're currently in, people are going to start going back to healthcare. And if there's nobody there to provide it, what do we do? So I think there are some big issues, there's some big policy issues for countries to grapple with that we want to highlight. And that's going to be one of the next pieces of work that we look at as part of our work.
Venkat, do you want to comment on that from India?
Yes, I think compared to several other countries, in India, there has never been a kind of a professional or a systematic approach towards a private sector engagement. There has been always a kind of either overbearing attitude, or maybe we have seen that in TB program. It took a while for us to really think about it in a more, systematic or a professional way. So if at all the India has to learn a great deal of lesson, it is about setting out a certain kind of institutional framework or dialogue forums or some kind of a system of relationship between the public sector and the private sector. It cannot be without HTA, without any kind of a costing exercise. We simply cannot have private sector engagement on the basis of certain notional values that the government wants to impose upon. So it's time for, this is an opportune time, if not, there's no other time that is as good as now, for the government to really think about making a more, what I am quoting as a professional approach towards engaging the private sector. So otherwise, the private sector is not going to really help in any other, times of crisis.
Thank you. Now we got permission from Petra to go 5 minutes over. So maybe the last question for you both, and Madhu as well. It goes to this point that you're raising about learning the lessons. And one of the questions we had posed was, is this engagement proving easier in countries, for example, in Africa that have made progress before now on PPP frameworks, etc., compared to other countries? And maybe starting with you, David, is there going to be the ability, do you think, to look back and review fairly promptly how this response has gone on in countries with different degrees of dialogue and framework in place in order to move the agenda forward?
Well, that's a really good question, because that's exactly what we are finding. The countries who already have infrastructure in place, already have institutionalized mechanisms for public-private dialogue, are doing a lot better. Those countries already have had some quite sophisticated discussions between the private sector and the government. And it tends to be also countries which have had very highly organized, highly private healthcare federations, and also countries that have had that have put in place these sorts of engagement institutionalize these engagement mechanisms. So both in terms of having these kind of formal public-private dialogue platforms, but also in terms of having staff in the ministries of health who work on this topic. So yes, most definitely. And in terms of the long-term view of all of this, yeah, we are definitely keeping track of all of these developments. And so we really do have two tracks for our work. One track is to try and share this information as quickly as we can with people while the pandemic is raging, the importance of these sorts of arrangements. And it's definitely something we emphasize in the action plan, this whole idea that we do need to have public-private dialogues about what the role of the private sector should be. And just listening to what Venkat said, what he was saying about India is certainly true for many countries. Lots of countries aren't organized. They don't necessarily have a policy on this, and they should. And then in terms of the longer term view, we think that health systems are going to be very different post-COVID, and that there is going to be a lot more interest in making sure that the private sector is more involved, both in terms of the things that the private sector can bring to health systems, but we're also conscious that post-COVID, money is going to be tight, and it's likely that we'll see more and more private provision and less public provision. So we have to think ahead in what future health systems are going to look like, and what the lessons from this COVID pandemic bring to us in relation to the whole topic of private sector engagement. So we're trying to do both.
Thanks very much, David. There were many other questions posed, and I'm sure, Petra, we can figure out how to make sure that people have access to answers in due course to those, but I'll turn it back to you now.
Okay, thank you. Thank you, everyone. I want to thank the speakers for the really wealthy questions and wealthy presentations, and really lots of details and lots of insights. I'm looking at Madhu. Did you want to say one closing statement? Or you? No. Okay. And thank you, everyone who has participated around the world. We've had about 25 questions, which is really showing that there is a lot of interest in this topic. The questions, thank you for moderating the questions, Guy. You've done a great job in picking out some of the key points and bringing them forward. And thanks very much, especially with the technical hiccups. It was really helpful to have you help out. And apologies for the technicalities in the middle of the presentation. We will be sharing all the presentations. We will be sharing the full recording. It will be available on our site. It will also be available on YouTube. I will take all the questions that have been asked so far, and I will be taking them up with the panelists. If there are any specific answers, we'll make sure that they will come back to you specifically and will be on our forum online so that you can engage with each other as well around these subjects. We're planning in another couple of weeks to have an extended debate actually on the engagement of the private sector and really look at the realities on the ground, talk with a few NGOs and with practical examples of how the private sector is engaged. So please watch this space, see how we'll put everything online and we'll keep you informed. Thank you very much for joining, and we look forward to next engagement in a couple of weeks. Thanks, everyone.
Thanks, Petra. Thank you. Thanks, everybody. Bye.